Hi, this is Piyush Bhargava and you're watching the Thyroid Scintigraphy teaching file. Let's quickly review the thyroid scan protocol first. So thyroid scans typically have two parts, the scan, which consists of pictures, and the thyroid uptake, which is typically a 24-hour uptake value that is calculated using a thyroid probe. The most common indication for doing a thyroid uptake and scan include hyperthyroidism, to evaluate the cause of hyperthyroidism, and to, based on that, see if radioactive iodine can be used to treat those patients. The radiopharmaceutical used for thyroid uptake and scan is 400 microcuries of I-123 sodium iodide, which is administered orally. I-123 sodium iodide has a half-life of 13 hours, has a single photo peak of 159 keV, and we use a pinhole collimator to image the thyroid. Typically that pinhole has a size of 4 millimeters. So after the patient is administered the sodium iodide capsule, they're typically called back the next day when we do the 24-hour uptake using the thyroid probe, and then we do the imaging using a pinhole collimator. The mechanism of uptake of radioactive iodine includes trapping and organification. Physiologic distribution is seen in the thyroid tissue, gastrointestinal tract, salivary glands, and some excretion into the urinary bladder. The critical organ is thyroid. This slide shows several graphs of thyroid uptake in different conditions. So let's look at the normal first, which is right here. So at 24-hour, the uptake is about 20%. The normal range of 24-hour uptake is 15 to 30%, with less than 15%, which is shown here, consistent with hypothyroidism, and more than 30%, which is shown in the two curves here, consistent with hyperthyroidism. So typically, or most of the times, patients who are hyperthyroid, when we do a 24-hour uptake, it's above 30%, which is seen here in this curve. It's above 40%. And there's a small subset of patients who we call hyperthyroidism with rapid turnover. In these patients, the uptake value goes above 30% in an early period, around 6 to 12 hours, and then may come back to normal value of 30% in 24 hours. So that is the reason why some centers do also a 6-hour uptake to catch those rapid metabolizers. Now let's start looking at some thyroid scans. Here, case number 1 shows the appearance of a normal thyroid scan. In an anterior projection, there is uniform uptake in the right lobe of thyroid and in the left lobe of thyroid. There is faint uptake in the isthmus as it goes around the anterior aspect of trachea. So this is a normal thyroid scan. Case number 2 shows a pattern which is seen typically with Graves' disease, where there is enlargement of both lobes of thyroid. There is diffuse increased uptake, as we see here in the right and the left lobes of thyroid. And because of the stimulation from thyroid stimulating immunoglobulins, there is appearance of pyramidal lobe activity, which is seen right here. The uptake value is typically more than 30%, and most of the times it's around 75 to 85, even 90%. So this pattern is consistent with Graves' disease. The next pattern is shown here in case number 3, where there is focal intense uptake in a nodule involving mid to lower portion of the left lobe of thyroid, with suppression of activity in the rest of the thyroid, consistent with a solitary toxic nodule. And in such patients, the 24-hour uptake value is still elevated. It's more than 30%, but after they are treated with radioactive iodine, this nodule, which will take up most of the radioactive iodine, is ablated over a period of time, and the uptake in the rest of the thyroid, which is suppressed currently, will come back and make the patient euthyroid. Here is another appearance of solitary toxic nodule, where the nodule occupies almost the entire right lobe of thyroid, with suppression of uptake in the entire left lobe of thyroid. Case number 5 shows another pattern which we call toxic multinodular goiter, or plumber's disease. Here we have multiple nodules in both lobes of thyroid which show increased uptake. The uptake value is more than 30%, and these patients are also good candidates for radioactive iodine therapy. Case number 6 shows another unique pattern where when we image the thyroid, there is barely any uptake, and the uptake value can range from 1 to 5%. So here you can see on this image there is background activity, there is no thyroid uptake seen, and this is consistent with subacute thyroiditis. And remember, these patients are not candidates for radioactive iodine treatment. Case number 7, this is a typical appearance of a cold nodule. The cold nodule is seen at the inferior pole of the right lobe of thyroid, and cold nodules can be cancerous. So the first thing we do is evaluate them with ultrasound to see if they're cystic or solid. If they're solid, they need a fine needle aspiration. So those are some of the patterns or common patterns that we see on thyroid uptake and scans. Now let's move on to I-131 whole body scans and first review the imaging protocol. These scans are typically performed in patients post-thyroidectomy. After they're diagnosed with thyroid cancer, the next step in management is to do a total thyroidectomy with or without bilateral neck dissection to remove the lymph nodes. The other indication is to see if they have any metastatic disease. These patients are patients with history of thyroid cancer. They get regional lymph nodes, they get lung metastases, and they get bone metastases. The way we do these studies is we orally administer these patients 5 millicuries of I-131 sodium iodide, wait for about 48 hours, which is 2 days, and then acquire anterior and posterior whole body images. I-131 is different from I-123. I-131 has a beta emission, and that is why we use it for thyroid therapies. It has a gamma emission, which has a photo peak of 364 keV, and it has a half-life of 8 days. Because of this high energy photo peak, we want to use a high energy collimator to image these patients. The mechanism of uptake is the same as I-123, trapping and organification of iodine. Physiologic distribution is the same as well, with uptake in thyroid tissue, gastrointestinal tract, salivary glands, and some excretion in the urinary bladder. On this slide, we have 2 whole body images in anterior and posterior projections showing the normal distribution of tracer in a whole body I-131 scan. The anterior image shows some uptake in the nasal area, oral cavity, some salivary gland uptake. There is no thyroid tissue in the neck. This patient is post-thyroidectomy. There is no residual thyroid tissue. There is no evidence of nodal metastases, bone metastases, or lung metastases. There is physiologic activity in the stomach. There is some faint uptake in the liver and excretion in the urinary bladder. Now, Thyrogen is a synthetic TSH which is administered intramuscularly when we do a thyrogen stimulated I-131 scan. Now, this is administered on Monday and Tuesday. I-131 is typically given orally on Wednesday, and the whole body images are acquired on Friday. Thyroglobulin is a serum marker for differentiated thyroid cancer and is followed after total thyroidectomy. When thyroglobulin is rising, that is an indication that probably thyroid cancer has recurred or there is metastatic disease, and that is when patients undergo an I-131 whole body scan. If the thyroglobulin if the I-131 scan is negative in that situation, then the next step is to do an FDG PET-CT scan, as the negative I-131 scan is telling us that the cancer may now be de-differentiated. It may not take up iodine, but it may take up FDG. Let's look at some I-131 whole body scans. Here we have a patient post-thyroidectomy referred for an I-131 scan, and there is some residual thyroid tissue in the neck, seen here in the anterior projection as 2 foci in the thyroidectomy bed. Now, this is something that can be treated with radioactive iodine. Another patient with similar finding post-thyroidectomy, residual thyroid tissue in the neck, which needs to be treated with I-131. Here is an interesting patient where the I-131 scan after thyroidectomy was negative, but their CT scan showed small bilateral miliary pulmonary nodules concerning for metastatic disease from differentiated thyroid cancer. So in this patient, it was decided to treat them with high dose of I-131. We gave them 200 millicuries, and on the delayed post-therapy scan, there is diffuse increased uptake in both lungs, seen best here on the posterior image, with uptake of I-131 seen in those bilateral miliary pulmonary nodules, confirming that they are metastatic disease from I-131, and at the same time treating them with I-131. Another scan with similar clinical history where the initial study was negative, but after treatment, 2 foci of increased uptake are seen. This is in the thyroidectomy bed. This is likely a focus in one of the anteriorly located ribs, consistent with bone metastases. This patient has metastatic differentiated thyroid cancer involving a left-sided submandibular lymph node seen here on the anterior image. The residual thyroid tissue in the neck is typically treated with a dose ranging from 60 to 100 millicuries of I-131. Nodal metastases are typically treated with a dose up to 150 millicuries of I-131, and if there are distant metastases such as lung and bone metastases, these patients are typically treated with a dose of up to 200 millicuries of I-131, and such treatments can be repeated up to 5 times for a total cumulative dose of 1 curie of I-131. Next case number 13, is showing whole body scans in anterior and posterior projections which are negative in a patient with rising thyroglobulin. The next step was to do an FDG PET, and the two images on the right, the image on the left is a MIP image in anterior projection showing 2 foci in the left side of the chest, and these 2 foci are localized to a nodule in the left lung and also a lymph node in the region of the mediastinum on the left. So these findings would be consistent with dedifferentiated thyroid cancer, which is now FDG avid but does not take up I-131. Case number 14 is another patient with similar findings, rising thyroglobulin and negative I-131 scan, and the whole body FDG PET-CT scan shown in this panel. The whole body image showing a focus in the right side of the neck, and that focus localizing to a right level 2B lymph node seen here as focal hypermetabolism, and also on the fused PET-CT image. Case number 15 shows I-131 whole body scans in a patient with bone metastases. They are best seen as the focus here involving one of the vertebral bodies and a linear focus involving one of the posterior ribs on the left. The interesting finding here is the correlation between the I-131 scan and the whole body bone scan, which is seen on the right. The focus in the vertebral body shows increased uptake of MDP, but the focus in the ribs shows a photopenic area, and we know that thyroid cancer bone metastases are lytic metastases, and so they will take up I-131 but may not take up technetium-99m MDP. Here is another interesting scan, actually an example of an artifact where whole body scan shows increased uptake in the region of the neck outside the patient's body, seen here on the anterior and also on the posterior image. And this was a female patient with long hairs covering her shoulders, and we suspected that there was, for some reason, I-131 activity in her hairs. When we asked to pull up her hairs above the head, which is seen here on this anterior image of the head and neck, the activity moved along with the hairs. So the hypothesis is that the I-131 was excreted from her scalp into the sweat, and over a period of time got accumulated in her hairs and is seen as an artifact. The scan itself is negative for residual or metastatic differentiated thyroid cancer. This is a finding that we see frequently, case number 17, where there is residual thyroid tissue in the neck, and when we image these patients, there is a starburst pattern which is seen here, and this is an artifact. You want to remember that this artifact is due to septal penetration because of the high gamma photon energy of I-131 of 364 keV. So remember, this artifact is called starburst pattern due to septal penetration. Case number 18 shows I-131 whole body scan performed as a part of post-therapy scan. They were known to have lung and bone metastases from differentiated thyroid cancer. They received 200 millicuries of I-131 for treatment, and 5 days later we did a post-therapy scan, and the post-therapy scan shows these foci which are better seen posteriorly in the spine and the pelvis, and some foci in the chest which are consistent with lung metastases. There is increased uptake in the liver, and that is because these metastases have taken up I-131. They have metabolized I-131 and made thyroid hormone, which is radioactive, and that thyroid hormone is next metabolized by the liver, because of which we see uptake in the liver. Case number 19, this is an example of thyroid uptake and scan in a patient with lingual thyroid. So in the region of the neck, there is no uptake of I-123. Remember, this is a thyroid uptake and scan using I-123 and not I-131. So in the region of the neck, there is no evidence of thyroid tissue, but in the region of the base of the tongue, there is a focus of increased uptake. And look at the CT scan. The image here in the bottom right is without IV contrast, showing the hyperattenuation of the lingual thyroid, and the other image is showing the contrast enhanced image, again hyperattenuating thyroid tissue at the base of the tongue. This is where the thyroid starts developing from, at the site of the foramen cecum at the base of the tongue, where the endoderm invaginates, travels anteriorly, and then develops thyroid tissue in the neck. And lingual thyroid is a developmental abnormality where there is thyroid tissue present at the base of the tongue, but there is absence of thyroid tissue in the neck. Case number 20, here we have a patient with history of thyroid cancer, post-thyroidectomy, and we did a I-131 whole body scan in anterior and posterior projections. We see residual thyroid tissue as two foci, one here more superiorly and one here more inferiorly in the thyroidectomy bed. And on the images on the right, the SPECT CT images, we are trying to localize these two foci. And as you can see here, the more superior focus, which is seen here, localizes to the site of foramen cecum, and this is stimulated thyroid tissue because of the thyrogen that was used to perform this I-131 scan. The more inferior focus is seen right here, which is residual thyroid tissue in the thyroidectomy bed, seen here on the SPECT CT. Case number 21, another great case with ultrasound correlation. Patient presented with hyperthyroidism. They had an ultrasound first, which shows enlarged left lobe of thyroid, right lobe of thyroid, with heterogeneous echogenicity and very prominent blood flow in both lobes of thyroid, consistent with ultrasound appearance of Graves' disease. They underwent a I-123 uptake and scan. Their uptake was pretty elevated, and the scan shows diffuse increased uptake in an enlarged right and the left lobe of thyroid. They were treated with radioactive iodine, and what I want to show here is how the appearance of thyroid changes from before I-131 treatment for Graves' disease to after I-131 treatment, where here you can see that the left lobe of thyroid has shrunk, it has decreased in size significantly, and so has the right lobe of thyroid shrunk and decreased in size significantly. Patient became hypothyroid, and they were started on Synthroid. The purpose of treatment using I-131 in patients who have Graves' disease is complete ablation of total thyroid tissue over a period of time and lifelong supplementation of thyroid hormones such as Synthroid. So we don't want them to have any normal thyroid tissue. We treat them with a dose ranging from 10 to 20 millicuries of I-131, and a specific dose is selected based on the 24-hour uptake value. The patient is treated with I-131, and over the next 4 to 6 weeks, they become hypothyroid, and that's when their TSH starts rising, and based on that, they're started on thyroid hormone supplementation, which they continue for the rest of their lives. Case number 22, patient with history of medullary thyroid cancer who presents with a new nodule in the right side of the neck. Now remember, medullary thyroid cancers are not differentiated thyroid cancers. They arise from parafollicular or the C cells that secrete calcitonin in the thyroid. And these are neuroendocrine in origin, so that tells us that we can also use indium-111 octreotide to image these patients. We can also use gallium-labeled dotatate to image these patients as well. So here is a CT scan on this patient which shows a new nodule in the right side of the neck in the submandibular region, and here is the ultrasound and the ultrasound guided FNA being performed, which confirmed that this patient had metastatic medullary thyroid cancer. So the next step was to do an FDG PET to stage their whole body. Here is a FDG PET CT scan showing the whole body image and the focus in the right side of the neck that we saw earlier, seen here, and another focus that we did not know of before, which is in the liver. So they have metastases in the right side of the neck, and they also have hepatic metastases. Both of them seen here as hypermetabolic on FDG PET CT. Last case for this teaching file, case number 23. Here we have two images from an I-123 uptake and scan. The image on the left shows heterogeneous uptake in both lobes of thyroid. The image on the right is with the markers. Here's one of the superior markers. The superior marker is typically placed at the thyroid cartilage, and the inferior marker is placed at the suprasternal notch. The interesting finding is to be able to find the inferior marker, which is right here. Both of them are anterior images, anterior image, anterior image. Image on the left is without the markers, image on the right is with the marker. Marker here is on the thyroid cartilage, marker here is at the sternal notch, and that tells us that the part of the thyroid or the activity that is extending inferiorly right here and right here is retrosternal in location, and this is a corresponding CT on the same patient showing the retrosternal extension of the goiter. Here's the right lobe of thyroid, which is enlarged and extending into the mediastinum. Here's the left lobe of thyroid, again enlarged and extending into the mediastinum. So those are some of the common patterns that you can encounter when reading thyroid uptake in scans, and also when you are reading the I-131 whole body scans in patients who have had thyroid cancer. Thanks for watching.